is legislative provisions supporting families experiencing financial hardship in the era of COVID-19. And today we are very grateful to have our esteemed colleague and principal investigator of the CMC CoIIN, Meg Camo, presenting. Thank you, Meg. So we'll go to the next slide. And just for people to remember, for the pop-up webinars, we do just keep them to an hour because they're just meant to be an opportunity to touch upon what are emergent issues and concerns and being responsive to where we are right now amidst so much upheaval around the pandemic, around the anti-racist movement that's been occurring with everything that's been happening globally. So first, let's do some welcome and housekeeping. So we are recording, so you are aware and can have that in mind. We're asking if people would please not use speakerphone just because it's makes it harder for participants to hear. And don't put us on hold because that hold music also makes it hard to hear. If you could, when you come on, we will mute you. So you'll need to mute and unmute yourself to participate, which we really strongly encourage participation. The whole point of this is creating the space for us to cross-share in real time and do that learning and understanding from each other and come away with something tangible that helps us in the work. So you can, at the bottom of the screen, when you hover your mouse, the arrow control bar pops up and there's the opportunity to mute there. You can also mute if you are on the phone by pressing *6 to mute and *6 again to unmute. If you have any technical issues in the chat box, you can certainly send those to Libby. And if you have anything you want to submit via chat to content questions or comments, you can throw those in the chat as well, and then we'll call upon you to speak further. Or if you have resources to share, we do save the chat and pull that out after. So all of that is very rich information. And if you can, take a moment to link your phone with your computer. It just lets us know who's here. If we go to the next screen, thank you. Then if you are on the computer after calling in via phone, then you can just enter the participant ID, which is by your name when you look at the participant list. And you can then bind your phone to the computer session by entering the number sign, that ID, and then the number sign again on your phone. So, and then if you look under join audio, you can find it if it's not popping up for you. Thank you, next slide. All right, so if you could all we'd love to just see who's here. People can just throw their name in the chat box. It's good for everyone to see. And it just lets us know who we have on the call from which teams so that we get a sense of the many folks that are joining today. And we're going to start with an introduction to the Catalyst Center. Meg's going to be wearing her Catalyst Center hat today. And then looking at an overview of the causes and consequences of financial hardship, and particularly in the context of CMC and COVID-19, looking at legislative initiatives, and then wrap up in next steps. And I don't think that there's anything else I need to say, is there?
I think we're good to go, Bethlyn. Thanks for that welcome.
Absolutely. Thank you, Meg. You take it away.
Great. So thank you all very much for joining us today, especially on a Friday afternoon. We appreciate it. I wanted to say thank you also for the pre-work that many of the state teams did. It was enormously helpful to us in sort of putting together our presentation today. I know that as I talk, Libby is going to help me if she recalls a specific example from a state that she thinks would be helpful to sort of elevate. She's going to call it out, but we also invite you all to call out those opportunities in the chat box as well to help facilitate state team sharing. We are going to post, if we haven't already, the results of the pre-work on the Box rather. We'll also upload the slide deck as we always do on Box, as well as the Catalyst Center fact sheets that I'm going to be talking about today. The slide deck might be especially helpful to you this time around because there are a lot of long web links in a lot of the slides, and we don't want you all to have to worry about trying to chase that information down. If we have that on Box, you can just go ahead and click on the active link so that we're hopeful it will be a facilitator for you. So today we're going to talk a little bit about some resources that the Catalyst Center has created to help Title V programs, but also their allies like family-to-family health information centers and state Medicaid programs and care coordinators in individual clinical settings. Help alleviate some of the financial hardship that many, many, many families of children with medical complexity and children in general and families in general are facing right now in this time of pandemic. I wanted to tell you just a little bit about the Catalyst Center. We are the Maternal and Child Health Bureau funded technical assistance center around improving healthcare coverage and financing of care for kids with special healthcare needs. We provide technical assistance to state Title V programs and their allies. We conduct policy research to identify and evaluate coverage and financing innovations. We create resources in order to spread those innovations. And most importantly, we connect those who are interested in individual states and across the country in working together to address these complex, multivariate problems and issues, and hopefully spread those innovative solutions to more kids and families. So you're all familiar with what's going on right now in this time of pandemic. We have a very, very serious health threat coupled with economic peril for many families. 2.3 million cases of COVID-19 and over 121,000 deaths. This is data from the CDC. 4.8 million unemployment claims since mid-March. I believe this was mid-March to mid-May, so those unemployment claims have increased since then from the data. 27 million people have lost their employer-sponsored health insurance as a result of having lost their job. There's a volatile stock market right now. You might wonder, why do we care about the stock market when we think about healthcare coverage? It's because many of the social service organizations that our families depend on for home and community-based supports live off of endowments, and the endowments live off of dividends. And so as the stock market goes up and down, the financing for those community-based organizations can become really unstable and challenging. And of course, there are going to be state and federal budget impacts, both on the short term and the long term. We'll be living with the economic consequences of COVID-19 long after, hopefully, the health threat is gotten under control, and hopefully that will be soon. I wanted to point out, as Bethlyn mentioned in the beginning of our introduction, we're living in this time of pandemic right now, but we're also living in a time of increased awareness and action around anti-racism. And so I wanted to just show you some statistics around hospitalizations. I chose hospitalizations rather than infections because hospitalizations are indicative of severity of illness. And you can see that as of June 12th, the age-adjusted hospitalization rates were highest among non-Hispanic, American Indian, or Alaskan Native, and non-Hispanic Black persons, followed by Hispanic and Latino persons. And so the severe illness related to COVID-19 is really hitting certain populations in a much more significant and severe way than it is others. And we think that that's just a really important thing to be aware of when we're thinking about these things. Those existing systemic health and social inequities are really being highlighted now, and they're really jumping out very clearly to us in terms of this data. We've been hearing voices from the field. We've been talking to family leaders and families across the country to try to figure out what's going on for kids and families, those with special healthcare needs in general, but also those with medical complexity in particular. And some of the identified needs, this isn't going to come as a surprise to anyone on this call, but as you know, financial hardship is significant, the loss of income, coverage loss as a result of job loss, changes in access to care and services. Many families are doing without their home health care services, their home nursing services. Everybody has switched to telehealth. There's just a whole different universe of care provision that's happening right now. The need for and the opportunity to strengthen existing partnerships and develop new ones is one of those opportunities that have come up as a result of the pandemic, according to the voices from the field. And so we thought that would be an important thing to share with you as well. Some of the strategies that are being used to address these needs are technical assistance around some of the new federal options. Congress has been thinking about these identified needs and has been trying through a variety of different legislative mechanisms to address them. Some of them are Medicaid and CHIP flexibilities, which were existing already that could be implemented during a public health emergency. Some of them are specific to the COVID-19 pandemic, like the CARES Act. And then we've also just sort of been able to think about a broader umbrella for some of these things in the area of care coordination. So a lot of care coordinators do work with families on a regular basis, on an everyday basis, around financial information and resource referral and around coverage and benefits counseling. It's key, it's foundational to being able to access healthcare is having a way to pay for it. And so one of the things that we've been thinking about in the Catalyst Center are what are some educational materials that we can help provide to our care coordination colleagues to help them in this work that they're doing with individual families, but also our Title V colleagues who are working on a population level. So we have a couple of opportunities here for resources, both technical assistance and training resources. The first is a new series of fact sheets that we've created. The goal was to provide Title V and allies with a summary of some of the guidance that has come out of legislative opportunities in clear language so that folks can better understand what's out there, what's available, to help support care coordination and partnership building activities, to inform benefits and coverage counseling, as I said, with the ultimate goal of aiding and reducing the risk of family financial hardship, which, as you all know, especially if you're familiar with the National Survey of Children's Health data, was already a significant problem for families of kids with special healthcare needs. You'll see at the bottom of this slide, there are links to each of the individual sets of fact sheets, and we're also, as I said, going to upload those to Box. So let's start to talk a little bit about those pre-existing public health emergency options that were available to states in the context now of COVID-19. So there are three of them. They sort of fall into three basic buckets. There's Medicaid Section 1135 waivers, 1915C home and community-based service waiver programs, and Appendix K, and then separate CHIP flexibilities. I'll talk just a little bit here about Medicaid Section 1135 waivers. By the way, you can also use Medicaid 1115 demonstration waiver to provide additional services or supports in a public health emergency, but the one that's specific to a public health emergency is 1135. And I know I'm throwing out lots and lots and lots of numbers and citations and all kinds of different things here, so please don't forget at any point during the presentation. I'm going pretty quickly because we only have an hour, but the Catalyst Center is always available to you all for questions, technical assistance. You can ring me up, we can talk things through, you can send an email. Our research assistants are happy to help at any point. So that resource is always available to you. So Medicaid Section 1135 waivers. So under a federally declared disaster or state of emergency, which we're in right now, 1135 of the Social Security Act has a number of flexibilities that can temporarily modify or waive certain Medicaid and CHIP requirements. So I'm going to give you some examples of some of the things that can happen as a result of these flexibilities. These are all optional for states, and a state puts in an application to the Centers for Medicare and Medicaid Services and says, these are the things that we want to waive, or these are the modifications that we'd like to apply for. And CMS reviews it and says, yes, you can have these, or no, you can't have these, whatever they decide. But so it's very individualized per state. Some states choose everything and some states are more selective. So we do have a resource available here for you shortly where you can find out more about what's happening specifically in your state. So one of the flexibilities under 1135 is provider enrollment or program participation rules. So for example, the limitations that currently exist under Medicaid around physicians and other clinicians practicing in states that they're not licensed in can be waived. Obviously, equivalent licensing in another state is still required, so you can't be a physical therapist in one state and provide respiratory services in another. You have to have equivalent licensing, but it really does allow, especially for those folks who maybe got caught outside their state when borders closed down, or when travel restrictions came in, or folks who have to shelter in place and were not necessarily at home, that can help get them access to care. Another one is around appeals and fair hearing. So speeding up the process for managed care enrollees to go right to a state fair hearing instead of dragging it out. If you need something more immediately in an emergency, you can cut down on the amount of time that it takes to go through that process for proceeding to a fair hearing, and extending the time period for requesting a fair hearing. If something has prevented you, you have somebody sick in your house that you're taking care of, and you didn't get around to requesting that fair hearing within the normal time frame, a state can offer the opportunity to extend that timeline. Some of the reporting and oversight requirements: suspension of requirements that a registered nurse supervise aides employed by home health or hospice agencies. When I first read this one, my first thought was, well, wait a minute, that's a patient safety provision. That's something that we're trying to do to make sure that the care is being provided under the appropriate oversight. Is that a good thing to be able to waive that? It actually can be. For example, if all of the registered nurses have been detailed to hospital work, they're all in the ICUs or in the emergency departments, they might not be available to provide that kind of oversight to aides. Under normal circumstances, those services would then have to stop. And so this allows those services to continue with the understanding and the expectation that as soon as humanly possible, those oversight opportunities will come back into play. So this is the slide I promised you with the link to find out what exactly your state has requested from CMS and what CMS has approved. This is the link. It's the Medicaid.gov website. I know it's not the most user-friendly website in the history of the world, but if you can make friends with it in some way, so there's oftentimes a lot of really interesting information. I would suggest, though, that especially in these incredibly busy times, don't spend a lot of time, sort of struggling through Medicaid.gov. If you're looking for something specific and it's not immediately obvious to you where to find it, give the Catalyst Center a call and we can help you. Section 1915C, Home and Community-Based Service Waivers. Appendix K is another one of these flexibilities that's available in a public health emergency. So you all are familiar probably with Section 1915C. It allows states and territories to request a waiver in order to provide home and community-based services to targeted beneficiaries with disabilities, as opposed to them being cared for in institutional settings. So a state that has a 1915C, and many states have many 1915Cs, a state that has one can apply for an appendix to that waiver and get a temporary standalone addition in order to be able to expand on some of the services that they're providing, or to be able to provide the services, the home and community-based services, in a different kind of way. So some examples of modifications or additions that are available under Appendix K include temporarily increasing the cost limits for entry into the waiver, or modifying other kinds of targeting criteria. State can decide that it's going to expand its waiver criteria under a public health emergency, or maintain eligibility without receiving services. Under a typical home and community-based service waiver, if you're not receiving services, then you get taken out of the waiver. But if for some reason, say you're not receiving home healthcare services because there's no PPE, or it's not safe, or there's no staff available, you're not going to get thrown out of the waiver as a result of not receiving services. So that's actually a good modification that can help keep people sort of in place and ready to pick up where they left off when the public health emergency is over. Another one is around covered service changes. So modifying service scope or coverage, increasing service limits, so you can give different kinds of services, you can give more kinds of services. You can do things like adding Meals on Wheels, or medical supplies, or equipment, or assistive technology. Those are all things that states can ask CMS for permission to provide to home and community-based service waiver beneficiaries. Service planning and delivery. So you can temporarily begin or expand services available under self-direction authority. And you can also adjust the assessment requirements. For example, instead of requiring that an assessment be done in person, it can be done over video or over the telephone. Another addition or waiver is around settings. So you can expand the settings in which home and community-based services are provided. You can pay for services that are provided in out-of-state settings, for example. Permitting payment for providers. For family members to be caregivers is one option. There are some states that do that ordinarily, but for other states that don't typically pay family caregivers for the care that they're providing to folks at home, you can have a temporary Appendix K that allows for that to happen, which can be really incredibly helpful to families who especially have either lost their job and are at home caring for family members, or for families whose regular care from outside the home is no longer able to come in. So, you know, it sort of falls onto the family member in order to provide that kind of care. So here is the place on Medicaid.gov where you can find a list of your state's approval letters with regard to Appendix K. And I think I mentioned this earlier, but just as just to make sure that I cover it, for each individual waiver that your state has, you need to have a different Appendix K. They can all look alike, but you have to have different ones. So say your state has 5 home and community-based service waivers. If you want to modify them all, you have to do 5 of them. You don't have to do all 5, but you do have to have 5 separate ones. They can all look identical, or they can all be different. You customize them based on the needs of the service population.
Meg, we have a quick question from the chat box before we move on.
I appreciate your help with that, Libby. I can't see the chat box. Thank you.
Mari, do you want to unmute and ask your question? If not, I'm happy to read it. Just give her a second. All right, I'll go ahead and read it. She asked, does Appendix K also allow for clinicians like dietitians to bill for phone visits?
I don't know the answer to that. I'm pretty sure it says physicians and other clinicians. I don't know if, you know, it gets into a lot of detail. I can certainly check that out and get back to everybody. I think maybe what we might do is create a document called Frequently Asked Questions and put it in the folder for this webinar on Box, because my guess is there are going to be a lot of really specific state-specific questions that I won't be able to answer off the top of my head, and we'll need to follow up with you all. So it'll be helpful to have that all collated in one place so that everybody gets access to the information. Is that okay? Does that sound all right?
Thanks, Meg.
Sure. So another bucket here is separate CHIP flexibility. So you all know that CHIP is the Children's Health Insurance Program. It's specifically for kids who are uninsured, but whose family income is generally higher than that available for Medicaid enrollment. So states that have separate CHIP programs that are run outside their Medicaid program, have an option to submit a separate disaster relief state plan amendment. The link in the slide here is to a table that shows which states have separate CHIP programs, which have CHIP programs that are run through their Medicaid program, and which states have a combination, have some of their CHIP money in Medicaid and some of their CHIP money in a separate program. So that's another resource for you all. If you're wondering, does the state have a separate CHIP program or not? You can go click on this link and see the table. So some of the flexibilities under this are to waive premiums, to waive cost sharing, to change application and redetermination policies, or to change verification requirements. It's basically, the rationale behind these flexibilities is to expand the opportunity for CHIP coverage if needed and chosen by the state, and to make it easier for kids and families to stay in CHIP if they get in, and to be able to offer them different things once they're in. And I just clicked on the wrong button. Sorry about that. This is the link on Medicaid.gov to see if your state has done a separate CHIP disaster relief spot. Again, if you get into this and you take a look and you look at what your state has applied for and what they've been approved for, and you have questions about it, please don't hesitate to contact Catalyst Center. We're happy to talk it through with you.
Meg, we got one more question about Appendix K.
Yep.
Oops. The question is from Adenika in Team Minnesota, and it's, is there a cap to the pay rate increase under Appendix K?
That is another good question. I don't know the answer to that.
Add it to the list.
Thank you, I appreciate it. It's good that these questions are coming into the chat because Zoom will automatically save a transcript of the chat. So we'll have them sort of memorialized. My guess is there would be some kind of a limit because the federal government has a financial interest in the money that goes into Medicaid. Medicaid is a state-federal partnership, so some of the funding comes from the feds and some of the funding comes from the state. And so my guess is there's a limit because the reimbursement rates are set by the state, but I'll have to check into that to be certain about it.
Thanks, Meg. I also wanted to give everyone an opportunity to chime in if they'd like. I know we had a majority of the states who submitted pre-work talked about some of the policies that have changed in their Medicaid program or CHIP. We had teams Alabama, Texas, and Wisconsin mention that in their pre-work, and we had some specific call outs about changes in eligibility from Alabama and Indiana, and also paying families for caregiving from Indiana, Minnesota, and Oregon. So I just wanted to see if anyone wanted to bring up some of these specific examples happening in their state. You can feel free to either type into the chat box or unmute.
This is Debbie Harris from Minnesota.
Hi, Debbie.
Hi. I know that, I think, and someone can correct me if this is incorrect, but the PCA hours for those who are caring for family members have increased so that if you have to care for your family member for more than, I think it's 40 hours a week, then that is allowed now during COVID, whereas it wasn't allowed before. So
I wonder, Debbie, if that's state specific, if that's one of those flexibilities that a state has to be specific about whether whether and how much they want to do that. We can check into that, but that's really helpful to know.
mm-hmm. Okay.
Thank you.
Uh-huh.
Yeah, especially where, you know, if you don't have your home health care coming in, there's no other option, but that families are providing care. So that's really helpful to know. I'm going to go ahead and jump now to something a little different. So we were talking just now about flexibilities and options that are available to states through Medicaid and CHIP, and they were created for any public health emergency. This legislation is congressional legislation that was passed back in late March. This is specifically called the CARES Act. It's $2.2 trillion to help address the health and economic impacts of the COVID-19 pandemic specifically. The first part that I want to talk about just a little bit is around health coverage, and I chose a couple of provisions that feel really important around healthcare coverage to make sure that you all are aware of. The first is an increase in the federal medical assistance percentage, or FMAP. I just mentioned that Medicaid is a federal state partnership. Some of the money comes from the state, some of the money comes from the feds. The money that comes from the feds is called the FMAP. So that's the amount of funding that the state gets in order to run their Medicaid program. The CARES Act increased the FMAP for each state by 6.2% from January 1st, so it was retroactive, all the way through the end of the emergency period. And the end of the emergency period isn't sort of an amorphous when your state goes to phase 3 or when your governor says, I guess we're all set, we're done now. It's actually the end of the federal declaration of the emergency period, which we don't know when that's going to be yet, but it'll be clearly defined. You might think 6.2%, gosh, for all the new people who are losing their jobs who are going to become eligible for Medicaid and all of the additional healthcare costs associated with taking care of people who are affected by a pandemic, 6.2 doesn't sound like that much money. When you're talking in the context, though, of a state budget, a state Medicaid budget, it's actually millions of dollars. It's a lot of money. And so it's a good incentive for states in order to make sure that you keep people on Medicaid. So in order to be eligible for that increase, states are required to maintain the eligibility standards and the premium schedule that they had in place January 1st. You can expand eligibility under 1135. You can't make eligibility tighter. You can't reduce it. You have to continue eligibility for current and new enrollees from March 18th through the end of the month of the emergency period. So that means that no Medicaid enrollees can be disenrolled from the program for any reason unless they move out of state or they disenroll themselves. So if you don't pay your premiums, you can't be thrown out. If you don't follow your work requirements, you can't be thrown out. If you don't put in your reapplication paperwork on time, you can't be thrown out. So that's actually a very important provision to make sure that those folks who are getting into Medicaid get to stay in Medicaid. There's a lot about telehealth that we are all in the midst of right now. It seems like we switched almost overnight to a brave new world of telehealth. States already had broad flexibility in covering telehealth through Medicaid. This Aqua link here will bring you to medicaid.gov with a lot more information about telehealth itself and telehealth toolkits for states, telehealth provisions. States can use Appendix K to allow case management to be offered by telephone or video conference to home and community-based service waiver recipients. In the, under normal circumstances, you would have to have had that in person. But that's just sort of another way to think about being able to expand. It's not just telehealth, but it's sort of teleaccess in ways that could be really helpful under the current circumstances. So there's a little bit about telehealth and relation to private insurance in the CARES Act as well. Section 3701 talks about those high deductible health plans. They're permitted to cover any telehealth services without cost sharing. So, you know, a high deductible health plan, you have to spend a certain amount of money before you start getting services covered. What this provision says is any service, a telehealth service, including those that are related to COVID-19, but not just, have to be covered without cost sharing prior to reaching your deductible. So being able to get access to care, being able to if you are worried that you have COVID-19, or if you do come down with COVID-19, being able to access healthcare because you have a high deductible health plan and you're worried about the cost, you wouldn't have to worry about that. That wouldn't be an artificial barrier to be able to get care. Individual and group plans, ordinarily, they are only allowed to make changes once a year. This provision allows them to make mid-year changes so that they can provide greater access to telehealth services. They can also reduce or eliminate cost sharing if they choose to. And so this flexibility applies to COVID-19 related services as well as any telehealth service. I want to talk a little bit now about the CARES Act and employment. So this is a really important piece of legislation that has a direct impact on family financial hardship. We all know that the economy is reeling in many, many ways. I want to talk a little bit about some of the pieces of the CARES Act that relate to income supports and some that relate to sick leave and family leave. So with regard to income supports, there are 3 sections in the CARES Act that directly impact income. The first is the Pandemic Unemployment Assistance section. It's in effect January 27th through December 31st. And basically what it says is under normal circumstances, unemployment is only allowed, unemployment benefits are only allowed for certain kinds of workers. And what this section does is it expands the definition of the workers for whom unemployment compensation is, they're eligible. So gig worker, somebody who drives for Uber or Lyft, a self-employed worker. Ordinarily, those folks are not eligible for unemployment, but under the pandemic, they are. If they're out of work related to COVID-19, and the specific circumstances where related to COVID-19 is defined as the worker or the worker's family member is sick with COVID-19, the worker's caring for a child whose school or daycare is closed, or the worker's place of employment is closed as a result of COVID-19. So this expands the population of folks, the definition of folks who are eligible for unemployment. The next one is the Pandemic Unemployment Compensation section. So this is an additional temporary federal payment of $600 per week for folks who are receiving unemployment. It's available to all recipients of traditional unemployment or those who are entering into unemployment through the previous section that we just talked about, the pandemic unemployment compensation section. And that's available until July 31st. One of the things that I think is happening now is there's a lot of conversation in Congress about whether this additional federal payment should be extended past July 31st. I don't know the latest on it because these things happen on a day-to-day basis, and something could have happened today that I just haven't read about yet. But you know, I haven't heard about anything being definitively confirmed yet about whether that's going to continue or not. But for some folks are actually able to be on unemployment and find that they're not subject to the financial hardship that they would be otherwise. And so that's actually a good thing because for many folks, unemployment insurance wasn't something that was really easy to live on to begin with. So another section, the last section that I want to talk about with regard to income supports is the Pandemic Emergency Unemployment Compensation section. So the traditional length of time for unemployment benefits, it varies between states. There's an average of 26 weeks. Some states have a longer period of time. Some states have a much shorter period of time, but the average is about 28 weeks. This section provides a continuation of wherever your state's traditional unemployment benefit time limit ends to an additional 13 weeks. In order to be eligible, individuals have to have exhausted their state benefits and be actively looking for work. The benefit is the state's regular unemployment compensation amount plus the additional $600. So between these three provisions, you have an expansion of the people who are eligible for unemployment, an additional payment of $600 under unemployment, and then an additional length of time for unemployment. I want to talk just a little bit now about emergency paid sick leave. So private employers with less than 500 employees, and I'd like to point out for our Title V colleagues, public agencies, are required to provide paid sick leave to employees who can't work for a COVID-19 related issue, like you have a federal, state, or local quarantine or isolation order. Your doctor has advised you to self-quarantine because you may be contagious, for example, or there may be one of your family members may be contagious. If you're experiencing symptoms of COVID-19 and you're in the midst of getting tested and getting confirmation of a diagnosis, caring for somebody who's under a quarantine order or self-quarantine medical advice, or caring for a child whose school or daycare is closed or whose childcare provider is unavailable due to COVID-19 related reasons. And it's my recollection that child here is also, it also includes adult disabled dependents. So, you know, if your day hab program is closed, for example, you would be eligible for this time.
Meg, we
yes.
have a quick question from the unemployment section if you want to go back a couple slides.
Sure.
This is from Adenike, sorry. Are there any additional tax implements for the unemployed in regards to additional unemployment benefits?
That is a fine and excellent question. Don't think so, but I don't know for sure. So again, that's another one we'll follow up on. You know, it just occurred to me that another thing that we should probably follow up on, if the time lapse between unemployment benefits and the FMAP, you can't be thrown off for not paying your premiums or for any reason other than you decide to self-disenroll or you move out of state. I don't know if any of that additional money would impact your Medicaid eligibility after that section times out. That would be something that we'd probably want to look at as well. Yeah. Thank you for helping me keep track of these excellent questions, Libby. I appreciate it. If you haven't had the chance to just plop that in the chat box, if you could just make a note, Medicaid implications, unemployment income, question mark? I'll go ahead and follow up on that one too.
I know Ben's keeping track of questions, so he's got it.
Thank you, Ben. All right, let's see, where did we leave off? Oh, yes, the Emergency Family and Medical Leave Expansion Act. So you all know that the existing Family Medical Leave Act is great in many ways, but it's unpaid. So in the CARES Act, they included some expansions of it. And it is relevant to employers with under 500 employees and public agencies. They're all responsible for complying with this. It provides for additional paid family and medical leave to employees who can't work because their child's school or daycare is closed, their child care provider is unavailable due to COVID-19 related issues. Again, adult disabled dependents are included in this. An employee can take up to 12 weeks of leave. The first 2 weeks have to be unpaid, but the remaining weeks are paid at 2/3 of the employee's regular pay. And compensation is calculated using the number of hours an employee would normally have been scheduled for. If you usually work 30 hours a week, then your compensation would be calculated on 2/3 of 30 hours a week. It is not 100% of your pay, and it's not 100% paid for the entire time period, but it is better than the traditional Family Medical Leave Act, which is completely unpaid. It looks like it's time for me to come to the disclaimers or the fine print. So I need to be very specific and say that this information was accurate as of the time I wrote it yesterday, not yesterday, a couple of days ago. But agency guidance is coming out every day. I literally get messages from CMS. There's probably 3 or 4 emails every day about new guidance, new regulations, new rules, new advisories. So this whole universe of legislative opportunities, but also statutory opportunities and rules and regulations opportunities, they're all changing very rapidly. And it may have an impact on the content I just spoke with you about. So for the most up-to-date information, you should visit medicaid.gov. There's a specific link here. And there are some wonderful documents on this link called Frequently Asked Questions. Some of them are divided up according to topic. Some of them are just more general and sort of lots of different things were thrown into them. But they can be really helpful in making sure that you are as up to date as you need to be on some of the things that are happening. Again, you can always call the Catalyst Center and we can help you think through these things as well. As is evidenced on today's webinar, I can't always answer every question. Our staff can't always answer every question right off the top of our heads, but we do know where to go for the information and we will be sure to follow up with you on it. We also have our traditional funding disclaimer here. Thank you, HRSA, for the money. We very much appreciate it. And we are just honored and thrilled to be able to do this work, both in collaboration with our federal colleagues, but also in collaboration with our Title V colleagues and their allies. So let's go ahead and open it up to questions and discussion. And I'm especially interested if there are models of how some of these things are happening operationally on the ground that you all did such a wonderful job of describing in your pre-work. If you'd like to elevate them and share them with your colleagues to sort of illustrate some of the more general things that I've been talking about, I think we'd all really appreciate the opportunity to learn from those.
Debbie, I see that you asked a question in the chat. Do you want to unmute and talk about that? I can go ahead and read it too if that's easier. Debbie asked,
Here I am. Sorry, I had to kind of shuffle between a couple of screens. Yes, is our employers with fewer than 500 employees required to pass on that information on the CARES Act to employees? For example, we have a PCA agency and they've been wonderful about sharing information that has come out since COVID in support of employees and families. So they've really kept us apprised of all of this. But our nursing agency, on the other hand, and I think just being protective of their revenue, they have shared no information at all. So families and staff in the homes have no idea what to do in any of these cases that you've mentioned, any of these scenarios. For example, if a family member gets sick with COVID, if you want to protect your child, if the nurse is exposed, for example. So some of these things that you mentioned in the CARES Act, for example, just perhaps the nurse, excuse me, having to take off time to protect the patient would have a significant impact on families who use home care, but we had no knowledge of it. So are they required to provide that information, or are you just kind of on your own in seeking it or digging it out or coming across it? So that's my question.
I don't recall seeing, I did read the legislation, all 900 and some odd pages of it. Some of it I skimmed, I'll admit, but I didn't see anything about a requirement for public education. And that's one of the reasons why we created these fact sheets, because we knew it was both important to get the information out in the context of care coordination. That feels like a very natural locus of this kind of information, because so many folks do work around information or referral around financial hardship for families, or they help families figure out what they're eligible for in terms of coverage counseling or benefits counseling. So I don't think that employers are required to share the information with, for example, clients. I do think that companies are required to share it with their employees, but the recipients of their services, I don't think there was a requirement around that. I don't recall seeing that. Again, that's another thing that we'll confirm for you all. That's a really helpful comment, Debbie, and it really highlights the need for information sharing, and especially for you all in thinking through what's happening in your individual state and making sure that you're connected with your other partners, because no one organization would find it easy to cover all the bases with the complexity of everything that's going on. So those partnerships, those community-based partnerships, those pre-existing colleagues that you had outside your organization, being able to have the opportunity to do peer mentoring and sharing with them now is more important than ever.
Thank you.
Thank you.
Meg?
Yes.
Hi, this is Adenike. I just wanted to thank you for your elaboration on the question that I had. And I know you said you don't have an answer yet when you guys are going to look it up and get the information back. But just to add, to that, I could just see this being a disaster next year if there are some type of tax implications and or penalties where parents who have parental fees who have not prepared for this because they were laid off from their full-time or part-time jobs outside of the world, but then they're still doing full-time caregiving at home.
Yep.
Does that make sense? like I could see that being so detrimental to them for their parental fees and just eligibility for healthcare in general.
Yep.
So I guess I can't see how it would benefit the powers that be to offer something like that to families without telling them ahead of time, by the way, this is coming later, but who knows?
It's been my experience. That's a really helpful point, and I appreciate your elevating it. I know for certain that the stimulus checks that everybody received, the $1,200 or whatever it was, there's no tax implication for that. That is tax-free money. But the additional income, either because you're being paid as a result of caregiving at home and you're doing more hours than you would have in your regular job, or you were taking care of your child without getting paid for it earlier and now you are, that's going to change your income picture. It's also important in terms of Medicaid eligibility. It's been my experience that people don't on purpose set up these kinds of scenarios where it's a problem for folks later down the line. They just don't think about it because they don't put all the pieces together. If we give somebody a benefit over here, this might be the unintended consequences of that later down the line. They don't have the opportunity to put those pieces together. So I think it's really important for us to be thinking about this now, because we know, and especially the family leaders who are on the call today, you all know holistically, you know those care maps, you know all those different entities that surround your child and your family. And so it's a little, I think, more natural for family members to put those pieces together. They think about those implications a little bit more naturally than folks do. Policymakers, for example, who are removed from the day-to-day, who maybe don't have the opportunity to think about it explicitly. So this is another opportunity for us to gather this kind of information, to not only share with you all what's available, but also in a bi-directional way to share back to those policymakers what could be the implications and what they should be doing now to try to make sure that that doesn't happen further down the line. Does that make sense?
It does. Thank you.
Sure. So we'll feed stuff that comes from them out and share it and disseminate it, but we also are collecting information from you all and hopefully being able to share it back to the people who are making these decisions and creating these opportunities.
We have a little conversation going on in the chat box about applying for waivers, and Tammy from Oregon asked a question, if any Title V agencies take the lead on applying for those. And I know that Barbara from Wisconsin and Susan from Alabama chimed in, so I wanted to see if either of you or anyone else wanted to speak to their answers.
Mm-hmm.
While they're unmuting and thinking, I'll just give a summary. So in Wisconsin, it sounds like the Department of Health Services and the Medicaid Bureau takes the lead on waivers. In Alabama, there's a variety of waivers administered by different agencies. At their Children and Youth with Special Healthcare Needs program, the care coordinators and parent consultants work to educate families around choices available for waiver slots and then help them in the application process. Does anyone else have comments on that process? Which agencies apply for certain waivers?
Yeah, I've been talking about Medicaid and CHIP waivers, but there are other kinds of opportunities out there. I'd love to learn more from the folks on the call.
In Wisconsin, we have a series of regional centers. This is Barbara, who have, we have 5 regional centers, and those regional centers, as well as partner organizations, take the lead in informing families about access to waivers and information about navigating and using and eligibility processes, et cetera, for waivers. But it's a county-driven system. So we have 72 counties, and the counties help the families. As far as applying for the federal waivers, it's our Medicaid Bureau within the Department of Health Services that applied federally for the waivers that Meg talked about.
Mm-hmm. Thank you, Barbara.
It also looks like Lisa chimed in saying in Indiana, it's our Bureau of Developmental Disabilities Services and Area Agency on Aging that they manage that.
Great, thank you.
And I wonder, I don't know if Lisa wants to speak to, I'm just curious, the point about how do families know? If anyone, is it through this agency that the different folks are talking about that are administering these and hold them? Or some other way that you're seeing it being educated, or are there ways which you'd like to hear more about how states are doing it? A question you might have about that, so that we can help get this information out to families.
Hey Meg, this is Tammy. Can I make a quick, I was just remembering back to when the ACA started and how we had that lovely system of application assisters that we knew that we could go to for accurate information that was actionable, and how wonderful that would be to have something like that in this time.
That really would be wonderful. That's a great opportunity to think.
Can you make that happen for us, Meg?
Oh, I wish I had that power, boy. I do think that it's a good opportunity, though, again, in the context of bidirectionally feeding back information to policymakers to think through some of this stuff. I mean, Congress invested trillions, and so they meant for it to make a difference. And so if it's not making a difference, I'm sure they'd want to know that. And so I'm sure that, you know, in the next legislative round of opportunities, they'd welcome ideas for how to operationalize what they'd already created in a better, more efficient way. That's a great idea. You know, one of the things that just occurs to me is one of the primary sources that we've heard from families and family leaders for information, this kind of information and education, is from other families. And you get that when you're sitting waiting for the bus to come at the bus stop, or you're sitting in the stands at the basketball game at night, or you're sitting in the physical therapist's waiting room. And because so many of us are at home right now under shelter in place, those opportunities, those natural opportunities to just see and talk to other parents have been substantially reduced. And so virtual ways of keeping in touch for that kind of peer mentoring and peer education and peer coaching, I think would be another thing that would be really important. So, you know, from the agency to the client, from the state agency to their staff, and then to the individual families they serve, but also families to families. And I don't use that phrase inadvertently, family to family. The importance of the family to family health information centers, I don't think could ever have been stronger. So I think that might be actually my last opportunity to bore you today. I think what we'll go ahead now is to turn the floor back over to Bethlen, who will walk us through next steps. And thank you very much for listening. Thank you in advance for using the Catalyst Center. We're happy to be helpful in any way that we can. Please don't hesitate. I hope that you'll find those fact sheets useful. And thank you for everything that you do for kids and families every day. It's incredibly impressive what people have been able to do, even under the most difficult of circumstances in this project. So thank you all. Bethlen, I'll go ahead and turn it back over to you.
Great, thank you. And thank you to everyone for your comments and questions and thoughts throughout, also extremely helpful. So wrap up and next steps. I appreciate everyone's putting more things that we got a lot more coming in too. So reach out with any further questions. You'll also see some things coming through the chat that, and we're going to continue with, we have the consultation visits and we're prepping for those virtually. So as you're looking at your data collection management processes during that visit, and we're also going to be doing things like looking at sustainability. We'll do a journey mapping session. We'll have graphic facilitators. So there's been a lot of information being pushed out, and your coach will help with that. And we'll help to coordinate visits with National Advisory Committee members and other consults that might be of use to you. So you can revert a box. There's a consultation visits folder within the state team materials where you can see information and agendas, and we ask state teams as they go whether we can post agendas they've done, so you'll be able to see those as we go. We've already had one with Team Texas and it went really well. So contact us with any ideas for what could be useful to you as we move forward. Particularly, we're going to be having a state team learning session in October, and we want to see what would be useful for you with that. For that, we have gotten, I don't know, have we sent this out, Libby? I forget where things are. Okay. So we have been getting a lot of information out back from you all about where you stand in relation to whether or not that would be in person or virtual, and we'll soon be sharing. But spoiler alert, it looks like virtual is the way to go. So we'll share that out to everybody. And I don't know if there was anything else to share besides that. I do want to point people back to the chat because there are a few more things going on in there. And if anyone else has any other questions that they know they'd like follow up on, please feel free to throw them in the chat now. And do remember to reach out to the Catalyst Center. I know that we're also going to be sharing this information out with our collaborative partners to be able to share and use. And last but not least, we have the evaluation, and Ben has put that into the chat box for you as well. And as you know, we do pay attention, so we appreciate your letting us know, especially right now, what's most useful for you, so we can support you in all the very good work you are doing in whatever sphere you may be needing to do that in right now. So we wish you all to be well. We thank you for being here. Thank you for your partnership. And thank you for the hope that you give us, and to be able to continue and know that we're all working towards something and holding that space at a difficult moment in our shared human history. And we're going to get somewhere with all that, to a better place. Together, we can push through and do that. So thank you. All right, so